resolve in one fashion. It could be more than 300 diseases or even 1,000 diseases. And it's actually more accurate, and the cost is much reduced. It's just like you go to Malaysia or other countries, you don't need to prepare one adapter that's good for many countries. So are you ready to utilize this technology, this test in your locality? Now, in Hong Kong or perhaps in many Southeast Asian countries, we only screen thalassemia during pregnancies. And this is a autosomal recessive disease. And in Hong Kong, the alpha carrier rate is about 5%, beta carrier rate is about 3%, and it could be even higher in your countries. And we screen this disease because they cause major morbidity and mortalities, such as in utero, anemia, and stillbirth, and then beta for alpha, and then for beta, they require regular blood transfusions after birth because of anemia. The screening method for thalassemia is also very simple. You just take an MCV and followed by diagnostic hemoglobin pattern, simple, accurate, and inexpensive, and just minimal false positive or false negative. So that's good to screen thalassemia. But is it justifiable to screen other genetic diseases? Now, of course, first question is, are they tested? Okay, so for tier 3, carrier rate 0.5%. If it is 5% as alpha thalassemia major, if the chance of having an alpha couple will be 5% times 5%. And then if they have a affected fetus, that will be the chance of 1/4. So overall, presence of alpha major will be 1 in 1,600. Okay. Now, if it is 2%, okay, 2% here, then we can also estimate that the presence of the affected patients will be 1 in 10,000, calculated in the similar principle. If it is a carrier rate of 1%, then it's 1 in 40,000. Right? So 0.5% carrier rate, the presence will be very low. Right? Now, but having said that, one single disease is uncommon, but if there are multiple major diseases together that we can screen, then the presence could be assigned as thalassemia. Let's give you an example. With a carrier rate of 2%, the incidence is 1 in 10,000. If you have 6 diseases with the same carrier rate, then the presence of affected patients will be 1 in 1,600. That is similar to alpha thalassemia major. Right. So if you can put one test and screen multiple diseases or at least have the same presence, right, then why not do it? So based on our previous work and research in Hong Kong, we actually identified a number of genetic diseases with a high carrier rate. Right? So these are the papers we published. So the highest, of course, is the GJB2-related non-syndromal hearing loss. Right? The carrier rate is 21%. Thalassemia is about 5%, as mentioned to you. But then for syndromal hearing loss like Usher syndromes, Paget syndromes, the carrier rate is 2 to 3%. Spinal muscular atrophy, as you remember from the session yesterday, right? The carrier rate is 2 to 3%. Congenital adrenal hyperplasia also reach 2%. Wilson disease, citric acid metabolic disorders also 2%. So already you can see that there's at least 6 diseases with a carrier rate higher than 6%, 2%, right? And they are major, right? With significant mobility, right? And even mortality to the affected children. And glycogen disease complete 1%, phenylketonuria 1%. So these are worth enough or common enough to be screened. Now, of course, the next question is whether it is cost effective to do so. Now, this is a paper published some years ago, trying to look into expanded screening for 176 genetic diseases, and they estimate that it could be cost effective to doing so compared to not screening. Now, of course, different locality may have different cost calculation and so on. But just to give you an example, here I missed one slide. Okay. Just to give you one example, SMA, carrier rate is 2.5%. So if there's 6,400 women, we do not perform carrier screening. There will be 4 carrier couples, and by chance, one out of 4 will have a major SMA babies. Okay? Now this is concordant with the data that Josephine John showed you. We have 4 babies screened by newborn screening in 26,000 pregnancies, babies. Okay? So let's say the cost for gene treatment and medical treatment to take care of this SMA baby is 20 million. Now, what if we perform carrier screening? We identify the 4 carrier couples, and then they go through IVF and PGT, and let's say 1/4 of them, or 3/4 of them, have successful IVF and babies, right? And with 3 normal babies, but no SMA babies. Cost of screening per test, $3,000 Hong Kong dollars, 6,400 ladies, and if they are positive, we screen their male partners. So this is about the cost of the screening, and this is about the cost of the IVF 4 times, and it's similar. Okay, do you think it's cost effective? Well, of course, it is. The cost is hypothetical, right? But it's close to reality, right? The incidence carrier rate is true. Now, of course, we need more statistical analysis, right? But I believe that it will be more cost effective with other diseases are included into calculations. I just mentioned SMA, right? But then for other diseases, the cost of screening will be the same, right? Because it's all in one test. Okay. The other cost is unrecoverable. This is the age of the woman. Is it important? Yes. Now, in Hong Kong, I think also in other countries, the pregnant woman's age is getting older and older. So 20 years ago, the mean age is for women with the first pregnancy is about 27 years old. Now it's 31 years old. And only 10% is higher than 35 years old. Now it's 22%, right? Double when compared to 2 decades ago. That means women getting older to have their first pregnancy, to cancel their first pregnancy. And if there is any miscarriage, a worse outcome, right, they will lose several months to prepare for the new pregnancy. And that is the major cost, right? And that is the cost that money cannot pay, right? Now, so in order to make sure they are healthy, they are medically well ready, right, to carry pregnancy, I think carrier screening is very important for them. Now, of course, expanded carrier screening has its own limitations, and in the past 2 days, I think you have already guessed some. First of all, it's good to check any single nucleotide or point mutations or deletions for monogenic diseases, but may not be good in the sense that some deletion or mutation may be unknown submissions, right? And that may cause some anxiety and so on, right? Second limitation is we only sequence exon, right? But some diseases are caused by mutation in the intron that will not be reviewed in the carrier screening program. Right? But that makes the test less expensive. We just focus on the 1% genome, the exon, right? Make it more affordable. Right? There may be some residual risk because we didn't check the intron and we didn't report the unknown 710 and so on. Right? But it's still a minor problem when compared to the chance of diagnosing the major carriers of major diseases. The second limitation is that they will use pseudogenes. Right? This morning we also cover pseudogenes, right? And this all happened in congenital adrenal hyperplasia and SMA, as well as other diseases. Right? And that may cause some false positive or some negative. Right? But with more stringent analysis, they may be minimized, and as well balancing the benefits of screening and not screening is still worth to go. The third limitation, however, cannot be deal with expanded carrier screening by NGS. That is, some diseases are leukotype repeats, like fragile X syndrome. Right? So this is an X chromosome with apparently a big point here, so that's why it's called fragile X syndrome. And this is due to a multiple repeats CGG in the promoter region of the FMR1 gene. Right? And this CGG repeats, right, cannot be diagnosable by the NGS. Right? And if the repeat is less than 55, it's normal. 55 to 200 is because of P mutations. As a carrier of this, the offspring may have a chance of expanding the repeats to more than 200, according to this table. If it's more than 200, then the offspring will be affected, because once it's more than 200, the genes, the promoter will be methylated and will inactivate the genes, and therefore the affected child, especially the boy, will have mental restriction, developmental delay, and a typical long face and so on. Now, it's not diagnosed by NGS, but it requires a specific PCR method, right, to screen it out, right, to quantify the number of repeats. And we also studied before the methodologies, and we also reported that in Hong Kong, the female carrier is 1 in 800, which is much more than what we thought 10 years ago, 20 years ago. Right? It is not as common as Caucasian, but it is not rare. Now, comparing the screening for Down syndrome and screening for fragile X. Now, without prenatal screening for Down syndrome, the incidence at birth would be 1 in 500. But now with anti-screening and NIPT screening, we can pick up most of them. And the actual incidence now, I think, will be 1 per 50,000. Well, in fragile X, we may now still affect 1 in 4,000 male or 1 in 8,000 female. Okay, so this probably has become the most common genetic cause of mental restriction. Right? Down syndrome has become extremely rare to the pediatricians. Now, we have prenatal screening for Downs, but we don't have prenatal screening for fragile X, because fragile X fetuses have no phenotype. They won't have an INT. They don't have structural malformations. The only way you can screen them is to screen the mothers. Okay, so in that sense, why should not do it? Fourth limitation is we focus on monogenic diseases. But then after these 2 days, you also know that there is chromosomal rearrangement. For example, Robertson's translocations. Right? If the mother or the father is a Robertson's translocation carrier, their offspring may have the chance of monosomy, trisomy, miscarriage, major malformation, and so on. Now, in general populations, the incidence of organ translocation carrier is 0.1%. Recurrence miscarriage populations, 1.1%. In fertile men's population is about 3%. If either one of the couples is a carrier, no need both parents are carriers, and it's not autosomal recessive disorder. Either one couple, either is a carrier, will cause the problem. So you can see there's 0.2% chance. And if one of them carrier, you will have at least 1/3 chance that 2/3 chance that the pregnancy may have miscarriage or major malformation. The other translocation is the reciprocal one, right? So I won't go through these pictures, right, but you have some idea. So also has 2/3 chance that their offspring may have partial trisomy, partial monosomy, end of miscarriage, major malformation, and so on. So in general population, reciprocal translocation carrier is estimated to be 0.2%. If either one of them is 0.4%. Okay? So 2/3 will have with carriage or adverse outcome. So it may affect 1 in 400 pregnancies. It's even more prevalent than monogenic diseases overall. So while we consider expanded carriagism for monogenic diseases, we should also consider to screen for this group of translocation carriers. Now, but of course, if you use karyotyping to screen them, it is very hard. Firstly, it's labor intensive. Secondly, karyotyping is of poor resolutions. Now, which is Albers and our teams previously, a few years ago, established this test like Como-6, it's a very good, very precise to detect some small inversion, deletion, translocation, and so on that karyotyping cannot be detected, and that's good for identifying the translocation carrier, and then plan for IVF and PGT, to allow them to have a better pregnancy outcome. So when is the best timing for expanded carrier screening? Now, we usually do it prenatally, like thalassemia, we have been doing it prenatally, but this is not the best time, There's a time constraint in making a diagnosis. When you identify the carrier couples, it also takes some time to make a diagnosis on the fetus. And there's a psychological stress during pregnancy. And there's also stressful in decision of terms of pregnancy of the affected fetus. And sometimes you diagnose the carrier mothers, there may be some intervention feasible for the fetus. For example, prevent fertilization for congenital adrenal hyperplasia. But you have to do it before 9 weeks of gestation, So in that sense, prenatal carrier screening is not optimal. Better to do it before conceptions. It's the best timing, but usually couples are not aware, not ready to do it. People always feel that they are the lucky ones, not the unlucky ones, so they don't have the awareness. And our clinicians, colleagues, also are not aware of this either. Before IVF, I think it's also a good timing because they will see the doctors before a expensive IVF cycles. Why not let them have a safer procedures by screening out the carrier status? These are good opportunities for pre-implantation diagnosis. And therefore, public education on clinical or genetic health is very important. Now, so last year we got funding from the Hong Kong Jockey Club to sponsor this genetic carrier screening for high-risk couples. So we identified those who have a consensuous marriage, adverse pregnancy outcomes in the past, and so on. So far we have screened about several hundred couples. We performed the monogenic genes panel in 300 couples, and then another 300 chromosomes. So we identified that the 22% of the couples are carrying the same genetic diseases, and 5% of them have balance translocations, right? And some of them are suitable for IVF and PGT, like SMA, Duchenne's muscular dystrophies, some metabolic diseases, and severe deafness. And we also identified 6 patients with residual translocations and 2 with organ translocations. Right? So this is really high risk, right? So you can see the prevalence is quite high compared to general population. So this is beneficial for them, right? So if we identify the carrier couples, what are the options for them? First of all, the implantation genetic diagnosis is suitable for SMA, CAH, etc. Some genetic diseases may not need prenatal treatment. With a timely postnatal diagnosis and treatment, the affected children can have a good outcome. This will happen in the majority of the IEM. Right? With the direct treatment, they will do well. But it is good to identify the parents so that they have a well-planned and a timely postnatal diagnosis. Now, some diseases are very severe, lethal, and not treatable. Right? In that situation, prenatal diagnosis may be followed by terminal of pregnancies, like fragile eggs. And some may be suitable for prenatal treatment. For example, as mentioned, CAH, congenital adrenal hyperplasia, and hypothalassemia, Pompe disease. For CAH, you know that there is a blockage of the production of cortisols, and therefore leading to excessive production of androgens. And this is affected females during the critical period of the development of the external genitalia at the 7 to 9 weeks of gestation. The excessive androgen will cause virilization, right? And to prevent it, we have to give steroid to suppress the production of excessive androgen, and it is effective, right? But we need to identify the carrier couple first. Thalassemia major, right? We can do an IV neutral transfusions followed by postnatal treatment that we have covered yesterday morning. We are also planning or researching the stem cell transplantation in utero. Excellent severe congenital immunodeficiency. This is also a genetic disease covered in the expanded carrier screening. Which is not common, but if we screen out the mother is a carrier, right? This disease can be successfully treated by IUT, IU transfusions of stem cell. This already reported in the 1990s. Pompe disease, autosomal recessive, incident one in 20,000, is a problem in the metabolism of glycogen. So the glycogen accumulates in the cells, that includes in the heart, causing cardiomegaly, in the brain or liver tissues, causing hypotonia, respiratory problem, muscle weakness, and so on. Right? Now, after birth, with the pediatricians make the diagnosis, they can treat this group of children with enzyme replacement. Right? This is good advances in the past decades. Now, however, the disease actually has a utero onset. And I show you this affected family. Right? Participants had died at infancy. Right? In utero onset, you can see that the muscle already thickened. So for the affected siblings, right, this is treated in utero using microwave enzyme replacement. Right? And with the early treatment, this baby actually has a good outcome. Right? So you can see that the heart is normal and compared to the after stripping without in vitro treatment. So for this case, at the time of reporting, is 15 months old and is normal development. So there are many things that we can do to help the carrier couples. The first step is we have to start doing the screening. So let me conclude here. So there's an update in the ACMG's guidelines on the carrier screening. We should offer third-tier screening with disease carrier rate at least 0.5%. So there is a NGS gene panels available to target on more than 300 monogenic diseases. Overall preference, significance, and is worth to screen and is cost effective. And there's a limitation of gene panels. Therefore, we should also consider chromoseq for biotranslocation and special PCR for fragile eggs. And we should grasp the best time for screening, that is pre-conception or pre-IVF. And there are many treatment options for carrier couples, not only TOP, but also pre-management diagnosis, prenatal treatment, postnatal, timely treatment, and so on. So, last question is, are you ready to provide the genetic carrier screening? And you should equip yourself, and you can consider to join our master course of molecular genetics to learn more. Okay.
Thank you very much, Professor Lam. You give a wonderful sharing how the expanded carrier screening has been implemented in Hong Kong and the impact in the society. So let's welcome our second